So when we look at the difference between the fit, unfit and frail, this is a numerical score that was derived from the frailty index that was developed by Antonio Palumbo and colleagues. And in that, it's associated with your level of comorbidities, your level of daily functionality as measured by ADL and IDL, and also a combination adding your age. Now, the problem with a lot of these geriatric assessment-based systems is that they are relatively blunt. You've got to start somewhere, but they are relatively blunt. And one example of that is the using of cohorting ages. So the IMWG frailty uses ages in decades. And therefore, as you move from one decade to the next, you automatically pick up points, which can mean you become deemed frail, even though there's no change in your physicality. So we and others are doing lots of work to try and see if we can improve how we delineate patient's fitness. For example, we have just opened a trial in the UK called Transform. It's a sub-study to the Myeloma XIV, and what this trial is doing is using trackers. Now, these trackers are not requiring older patients to be tech savvy. They basically strap on the patient, we take them off a month later, download the data, replace the battery, and off they go. Now, these will give us sedentary, non-sedentary time, physical activities, a pedometer there will give us steps. Unfortunately, the devices don't have altimeters, so we won't be able to pick up fall rates, which is again another key. But what this will do is objectify people's physical activity, and we aim that this will replace the use of ADL, IDL, and also performance status. So in that context, with regards to treatment, we look at people in these three groups and decide that we do unaltered treatment delivery for the fit, modified for the unfit potentially, and then particularly modified for the frail. But as I've said before on occasions, these scores have not been deemed to be predictive, so there is no evidence base to use them to determine that, but there is some clinical rationale. The myeloma fitness study will aim to actually prove whether we can or cannot use that. The other thing to remember is that an individual's level of frailty at diagnosis can be modified because there's a disease overlay. So when you're diagnosed with myeloma, you have end organ damage and therefore you require treatment. That end organ damage can actually accelerate or augment an individual's physical limitations. And what we've found, and we're hoping to present some of this data at ASH this year, is that with treatment, as you control the disease, you can actually see improvements in people's level of fitness, including frail patients. We have some frail patients who bounce from being frail to being fit as a consequence of controlling the disease. So there is more to this than just a simple three-group categorization. And the last thing I would say is that within the frail population, there is what I would call ultra-frail patients. Now, we have a scoring system in the UK called the Myeloma Risk Profile, or MRP. And there's about 70% concordance with the frailty score. However, if we take people who are classified as frail under the IMWG frailty score, and then apply to those the MRP, we can segregate out a higher risk frail population or ultra frail population. And this is what I've done on real world data sets. I'm now going back to clinical trial, large data sets to test and validate this, but it may be a way of actually delineating those patients who, no matter what you do treatment wise, they will not improve their fitness and they have inferior outcomes, higher vulnerability to treatment toxicities.